looks like we've stabilized a little bit folks who are coming into the room. So welcome everybody. We're very happy to have you in this session on the Obstetric Rapid Response Team. And I'm sure you know now, after having been in breakout sessions, to please go ahead and type any questions that you have into the Q&A box, or anything else you want to share into the chat box. If anybody wants to speak, let us know, and we'll have our program coordinator unmute you so that you can speak maybe during the Q&A. So I'm going to go ahead and introduce Dilys, who will then, I think, go ahead and introduce Annette. So Dilys Walker is a professor in the Department of OBGYN and the Institute for Global Health Sciences at the University of California in San Francisco, with more than 20 years of global maternal, newborn, and child health, family planning, and reproductive health implementation research. So I'll let her add anything that she would like to that, and then Dilys will go ahead and present her co-presenter, Annette Osimbo. I hope I'm pronouncing that correctly, Annette. So Dilys, please go ahead.
Great, thanks very much. Thanks, Patricia. And thanks to the organizers of this conference for giving Annette and myself the opportunity to present this sort of new program that we've just piloted in Mozambique. Our initial attention had been to share with you some other more expanded pilot training program that we are intending to implement in Madagascar, although that's been delayed due to the COVID-19 pandemic. So the work that we're going to talk to you about briefly today is being done in collaboration with FHI 360 and the Alcançar project in Mozambique. And that's the context of what we're going to be talking about. So I don't need to tell many of you that it was probably over 20 years ago that the concept of obstetric first aid was first introduced into this type of, into emergency response for obstetrics. And since then, there's been lots of trials that have looked at communities trainings, TBA training, provider trainings, and lots of them, to be honest, have failed to show any significant impact. More recently, we heard yesterday, and we all are hearing more about WHO's promotion of the postpartum hemorrhage first response bundle. And as with many of you that are working within MNCH, I think we all appreciate that it's not so much what needs to be done when a woman starts to bleed, it's really about how. How do you get those actions and those practices to be carried out effectively, efficiently, and done every time? And this is how we developed this idea of an obstetric rapid response team for really to break down both these training silos and the response silos to emergency response. So just for a little context, we all know across the globe that there are lots of midwives and nurses who are the sole provider to birthing women. When a woman begins to bleed, they simply are unable to perform everything that needs to be done alone, even if they actually know what they should be doing. So we stepped back and thought, but are they really alone? Usually there's an assistant or a cleaner, or maybe an ambulance driver, or maybe even a family member. So with Pronto's experience in building teams and understanding the power of those teams, we decided to develop a solution that would enable frontline providers who often work alone to leverage all their available human responses, even those that are non-clinical, to build this culture and spirit of an emergency response team. And this would require really carefully defining both those critical, and they're both critical, clinical and non-clinical roles, and how to act together such that they're more likely to be able to save a life. And we call this the Obstetric Rapid Response Team, and that's what we're going to talk to you a bit about today. Let's see. So let me tell you briefly about Pronto International. It's an NGO that implements innovative training strategies that aim to act as a catalyst for healthcare providers to make individual, team, and actually system changes through simulation and team training. We've implemented various simulation and team training programs, often supporting big implementing partners that have capacity strengthening programs. And all of these programs are customized to the local setting and to the local needs, but there are 4 foundations to all of our work. We use effective, highly realistic, low-tech simulation and debriefing. We work actively to train teams in teamwork and communication. We have mechanisms to empower those teams to identify and respond to system gaps that are inevitably uncovered during these simulation activities. And all this is with the core foundation of kind and respectful care that is practiced with each simulation. So let me introduce you to just what is the Obstetric Rapid Response Team. When we were conceptualizing a new way to think about emergency response in lower level facilities, we decided it was important to change the language around roles and not be roles that were doctor roles or nurse roles, but roles that instead expanded that to be more functional around those roles that are critical to an activator, a responder, and a mover. So by that we mean, whenever there's an emergency, somebody needs to recognize that emergency and call that out so that the rest of the response falls into place. That has both clinical tasks and non-clinical tasks. Then there's the responder, who tends to be the clinician to do the clinical tasks and behaviors, but those anyone will recognize need to be supported by non-clinical practices, particularly when you're alone, and those need to be equally coordinated, as is putting in the IV or administering the medication. And then finally, the idea of a mover needs to be that concept needs to be triggered very early on in the response so that they're ready to move that patient to a higher level. Again, that requires clinical and non-clinical tasks that have to be coordinated. So in Mozambique, we piloted this with a focus particularly on the activator responder roles. And we're in the Madagascar program is really developing all 3 of these and the team training to actually practice them. I'm now going to pass the mic to my friend and colleague, Annette Osimbo. She's a nurse midwife from Western Kenya. She's been working with Pronto for quite a number of years now and has become a master trainer and has been trained in a number of countries outside her home of Kenya. Annette?
Thank you, Dilis. Hello, everyone. So let me tell you briefly about Mozambique. As you can see in the slide, despite important advances like having 70% birth done by skilled birth attendants, that is by 2015 estimation, Mozambique still continues to have high maternal mortality rates. They have traditional midwives who play an important role in rural Mozambique communities. These TBAs have been trained in things like misoprostol administration, chlorhexidine, cord care, and even blood estimation, and they are posted in some of the health facilities, though what we realize they are not paid. So as part of year 1 in the Alcanzar, that is Achieve project in Nampula province, as we can see in the map of Mozambique, pictured red, Pronto piloted this approach to emergency care with nurses and traditional midwives. Next. So we can see those pictures. Those are images from the training and the simulated pictures. We can see the first one having blood. That is a PPH simulation. The nurses are taking care of the mother and managing the PPH, and the TBAs are holding the baby. So I'm going to tell you about the obstetric rapid response team training we implemented in Mozambique. This included the TBAs and the nurses. This is because given the presence of TBAs posted at facility, as mentioned earlier, it created an important opportunity to test this interprofessional training. Remember, the objective of this training was not to train the traditional midwives outside their professional scope, no, but rather to integrate them more intentionally into the healthcare system. How? By recognizing their value and even creating a coordinated team to support the nurses during a PPH emergency when they are available. That is, when TBS are together with the nurses, how can they work together? Next. So this training, it was 5 days. The first 2 days, we trained 7 traditional midwives. They were introduced to pronto simulation methodology. We didn't involve the nurses because they had previously been exposed to pronto. So on day 3, 14 nurses now joined the TBS, and the cohort was introduced to the concept of obstetric rapid response team. So throughout the training, through simulations that we had and teamwork activities, nurses and TBS practiced the obstetric team response to an emergency with their clearly defined activator, responder, and mover roles that has been mentioned earlier by Dilys. Next. So, being the first training of its kind in the region, we had several successes. And one of them is that all parties were excited by the content and eager to implement the program, because seeing TBS working together with nurses and managing an emergency, especially PPH emergency, with the skilling a lot of mothers, that was one. Then the second one, nurses develop a new appreciation for TBS. Previously, nurses weren't activating or alerting any other people in the house, in the ward, during an emergency, because they felt they were alone and needed another clinician, someone who is knowledgeable. So this training was targeted at shifting that mindset and for them to utilize all available human resource during an emergency. I'll quote, as one of the nurses said, "Sometimes I know there is an emergency and yet no one is helping me. Now I might realize that, I haven't activated anyone. They don't know there is an emergency." And this was through a communication concept that we had during teamwork, like call out, calling for another help. Another success is that we discovered nurses often feel unable to give patient comfort care due to personnel shortages. A robust discussion during debriefing after simulation concluded that patient comfort care, such as massaging the back, communicating to the patient in local languages, taking care of the baby, which is often provided by TBS, should be valued and promoted by all healthcare workers. Next.
Hey, Jeff.
Hey, just curious, what do you think about how delayed are we?
Yeah,
Hello?
I emailed you. I think we're going to have everybody come back in at 10:10. That's what we've instructed all of
Hi,
us.
sorry. Sounds like somebody didn't mute their
Oh, okay.
microphone.
Started.
Just got the email.
Sarah, I don't know if you can mute that.
Is that good by you?
Yeah, that's fine. And
Yeah.
then,
Christina, can you hear me? Hold on, let me try to type to them. I'm not sure.
Yeah.
Annette, I'm
we'll
so
have to go over
sorry.
it. I think John will
It's
just have
okay,
to
it's okay.
that.
We'll have it figured out in just a minute.
when they come back, is there, John's going to do some brief introduction. Is that right?
Yeah, I don't want Annette to try to be talking over that.
Yeah.
Or is John have
Sounds like they're just trying to figure out some logistics here.
Sorry, I need to chat. I'm being
Can
told
you
that
chat,
they can hear
Christina,
me
and
in
let
some
them know
other
that we
room.
can
Give me
hear
one
them?
second.
Yeah, she's trying to do
Yeah,
that.
I just did, and I honestly don't, I don't even see them in here, so I don't know where that is.
I know. I don't know where it's coming from.
Is that
Okay,
okay?
sounds like maybe, oh,
Okay, good. Yeah.
maybe they're
Is
done.
okay?
Okay. All right,
It's
let's try
okay.
again, Annette. Please go ahead. Thank you.
Sorry for that. It's okay. So I was saying that another success that we had is that nurses began to recognize the importance and the value of information TBS can offer. Because sometimes TBS could give information, but because they felt that these are not knowledgeable, they couldn't get information from them. I'll quote again as one of the nurses said, they, the TBS, criticize sometimes the attitude of nurses, the way we treat them when they bring a patient to the facility. So I learned that when they bring a patient, maybe the TBA has been the activator in the community. So when she brings a patient, we need to pay attention to what she is saying. That is what one of the nurses said. So those are some of the successes we got. And however, as much as we had successes, we had challenges too. And these challenges from this training will guide us in the future trainings. In Mozambique, as in many countries, I'll say, TBS speak a local language that is very different from providers, which can complicate training and communication among team workers. Remember, we want them to understand one another, but if they're not being able to communicate because of language barrier, then it becomes a problem. But at the end of the training, we want everyone to get what the training was all about and to create that good teamwork among themselves. Another challenge is that nurses and midwives value each other, yes, but there remains a tension that is mostly out of their control. Tension of hierarchy. You are paid, we are not paid. You are knowledgeable, we are not knowledgeable. So this hierarchy brings about tension, and it brings about gap between the nurses and the midwives. So this training, while technically works to shift the mindset around clinical and non-clinical personnel to work together as a team, because we want them to change, like to get those hierarchy out of their minds and be able to work together. This kind of shift is not immediate. It requires more than one training with lots of practice. So at the start of this training, participants expect session and sexism in the model. They were wondering, how are they going to cope? How are they going to sit together as a team? However, if you can overcome the initial discomfort and create safe space, it is remarkable how minds can shift at the end of the training. Thank you. Dilys, welcome. Continue.
Thanks, Annette. Appreciate that. This is just the last slide to sort of summarize some of what the things we learned and what we're thinking about as we begin planning to implement this in Madagascar. And that these issues around paid, unpaid personnel and how they are included equally and what that means and considerations of whether that is equitable and appropriate. The issues around generational gap and how people can learn across generations and education gaps. Those are things that we really want to use as transform from challenges into opportunities, which they actually are. And this idea of safe space that Annette mentioned, is probably the #1 most important thing for this sort of training to work. And creating that safe space takes some time and has to be very intentional. And then finally, this idea of moving the role of mover more actively into it is planned for our following trainings in the obstetric rapid response team training, which is quite a mouthful. So with that, and to leave a few minutes for questions, I want to thank Annette, for her being able to make this from Kenya, and to the collaborators at Alcanzar in Mozambique who may be here and were certainly extremely supportive of this work. And then finally, the team at Pronto International headquarters and our master trainers like Annette around the world. Thank you.
Great. Thank you so much, Dilys and Annette. That was a very succinct but informative presentation, so we appreciate it. We do have a comment in the Q&A section, and please, anybody who has comments or questions, feel free to type, or if you would like us to unmute you, let us know and we can do that. So Annette and Dilys, the comment is from Peter Mutanda, who says, thank you for the presentation. There are quite a few training modules out there, and this can be overwhelming to healthcare workers. In Kenya, the Ministry of Health is putting together a standardized mentorship package that includes such drills. So I don't know, Annette, if you're aware of that, if you want to comment on that maybe?
Yeah, I'll say in Kenya, we have this because Pronto was introduced to Kenya some time back, and Pronto has been in communication with Ministry of Health to see how to synchronize Pronto together, because Pronto is all about EMOC, but now we are doing EMOC in terms of simulation and also with the package of teamwork and communication. So this is still in work because the Ministry of Health have this, so they are still working it out to see how do they incorporate simulation with the other mentorship activities, so that they roll it now down. They put it into the guidelines and they roll it now down throughout the country. But in some of the facility, they're already doing this. Few counties, not all.
Okay, great. Thanks, Annette. Dilys, did you have anything to add?
No, I think that's fine. I think the difference here is the intentionality of this new program, which really changes some of the language around roles that we think will help facilitate bringing it in more broadly.
Great. Okay, thank you. And another question from Robin Churchill. Great presentation, thanks. Any thoughts on how to integrate TBAs in countries where MOH government opposes formalizing the TB role in any way?
Yeah, that's really interesting because this has come up in a number of countries already where you're actually not even allowed to use the word TBA and that they're being transformed into companions, which is obviously a very important role. But we believe that this intentional transition to use language like activator, responder, mover will take away that threat that we're trying to have traditional birth attendants perform clinical tasks that may not be in their scope of practice, and get a recognition that both clinical and non-clinical practices and behaviors are critical in order to have a successful response. So what we're trying to do is not even talk about them as TBAs. We're talking about them as members of this team that is critical to respond to an emergency, that it doesn't matter if it's a nurse, a doctor, a TBA, ambulance driver, a pharmacy worker. It's how do we teach whoever is the frontline worker, the clinician, to optimize who they have at the particular moment.
Thanks, Dilys. Annette, did you want to add anything to that?
No. Thank you.
Okay. We have, let's see, I think our time is almost up. Is that right, Sarah? We're supposed to have folks go back into...
The session, I think, is now ending at 10:10, so
we're at time. Okay, all right. Any last questions, comments from anybody? Sam has his hand up. Can you try to unmute Sam? Sarah, at the top of the participant list there.
yeah, Sam, if you want to unmute, you can talk now if you'd like. Do you have a question?
Sam, if you can unmute, you can go ahead and ask your question. If we have time, we'll see if they let us take a little bit of time here. Huh, he may be having trouble unmuting.
I also did see one more question in the Q&A box, Patricia, but we...
Oh, sorry. Okay, I've been...
To send that to the presenters and they might be able to answer it offline. I just don't want to delay folks rejoining the plenary.
So if folks are going to stay, the question is, again, from Peter, there isn't a uniform agreement about working with TBAs. We may need further evidence or well packaged to get buy-in from both national and regional health leaders.
Yeah,
So,
yeah, very quickly, we absolutely need new evidence. And I think, again, it's not about working with TBAs. It's recognizing that any facility needs an obstetric response team. And that's the key, whether it's TBAs. And what happens is teams in the facilities recognize one of their key resources is the TBA, and how can we make sure that we're taking advantage of that? And it's for them to recognize, not for us to impose.
Okay, thanks. I guess the
Very
question has
true.
been running.
And also,
Oh, sorry, go ahead, Annette. Yes, sorry.
I was saying in the presentation, we mentioned that why we use TBAs in Mozambique is it is because TBAs are working in the facilities. So can the team recognize that they can use the TBA around? But as Dilly say, it is not only about TBAs. Anybody around in the facility, can they respond to an emergency? Thank you.
Okay, thank you, Annette. I guess just one question I was going to ask, since we don't have any more in the question box, is around what you mentioned, I think, Dillis, the whole area of paid, unpaid, and equity, given that TBAs tend to be women, and you said that you're exploring the dynamics of that. It would just be interesting to know kind of what you're doing and how we can address that, you know, given all the issues around gender roles and equity and those kinds of things in the countries that we're working in.
Yeah, I am absolutely feel that that was not really a surprise, but the importance of that and how we really, if this is going to be successful, we're going to have to figure out a way to address it and have all of the stakeholders recognize the importance of this, and that any ideas you have, we are welcome to hear them, because I think it's going to be an issue moving forward.
And I think it is for all community level health workers who are probably most of whom are not paid at this point. And yeah, lots of issues around that. But it's great to know that you're looking at that you're not letting this get in the way, but you're kind of piggybacking those issues onto what you're trying to do to offer quality services at a time and place that are really needed. So thank you. It's almost 10:15. I don't see a slide. Sarah, are they going to put a slide up for telling people what to do? Yeah, where to go next? There we go. Speak of the devil, there we are. So I think, again, I thank folks. I certainly thank Dillis and Annette for fantastic presentations. I learned a lot. I enjoyed listening to them. So thank you to all attendees. And please go ahead and click on the link that you see here in the chat box and on the slide, and you can go back into your next session. So with that, I will end the session with thanks to everybody and wishing you all a good day, afternoon, and evening.
Great. Thank you very much.
Thanks again, Dillis and Annette.
Appreciate it.
Okay. Bye-bye.
Thank you too.
Thank you.
Bye.